So it's interesting to me. I came today to talk about step one. It always fascinates me how many people want to hear me talk about a test I never took. But it's fun for me because, if you got your dissertation in math anxiety, you like talking about difficult things. And this is a thing that people, I think, do find difficult. I don't have any conflicts of interest to disclose. I will mention certain commercial products. I have no financial interest in any of them, nor am I recommending any of them in particular. We're not going to talk about drugs today, but if I were, I would be FDA compliant. Okay. Objectives and overview. So most of this information you could totally look up for yourself, but I feel like it's important to have a conversation about how all the information fits together depending upon what sphere you're coming from, whether you're from the graduate side of med ed, the undergraduate side, the student side. And so really it's a look at what the data tells us about where we've been, where we are, and kind of where we're going and what impact that has had on all of us and our learners. I'll speak a bit about the future of Step 1 scoring, which, as a lot of people in the room know right now, is at issue, and then maybe some action steps depending upon where we're sitting about how we could sort of help the learner climate around Step 1. So first we're going to talk about what we know about Step 1, and I use the word know so loosely. We have a lot of data on Step 1. A lot of the studies are single institutions, so they tend to be a bit smaller scale, but you do see a convergence effect, and there are some larger scale studies. So here's what we know, and this probably won't surprise anybody. Step 1 is most effective near its cutoff point, and that's because for those of you who are interested in psychometrics in the room, it was made using the Angoff method, which, if you don't know, is asking committees of experts, hey, for this question, how many minimally acceptable testers would get it right? What do you think? 30%, 50%? But what that gives you is a test that's actually really good at separating those who should pass and those who should not pass. We're very confident that those who fail Step 1 probably aren't competent to move to the next phase of their medical education. And then in a move that should shock no one, just like if I'm really good at driving a car, perhaps I'd pick up driving a truck pretty quickly, it can predict performance on other similar objective standardized exams. And so let's dig into that data a little bit, because this is usually how people justify the way we use Step 1. They're like, but it does tell us how somebody's going to do in the future. And the answer is yes, but, or yes, and. So what we know is that Step 1 does have correlation with NBME subject exam or shelf exam scores. Now, the most interesting study on this was done at the Mayo Clinic. They did several years of their 30-year students. And what they found was that if the student could clear a 220 on STEP, they were at functionally no risk of being below the 10th percentile or marginal on a shelf exam. So again, more accurate, closer to the cutoff. It's very good at predicting risk. It's not very good at predicting how high you can go. Same thing for Step 2 CK. There's a good correlation, but most of the studies kind of show that the correlation's not the whole story. It's not a one-to-one relationship. There's a lot that happens between Step 1 and Step 2. In my mind, the most interesting stuff is what it says about residency performance. We do know that Step 1 performance is highly correlated with your performance on your in-training and your board exams, but again, not the whole story. So let's talk about maybe anesthesia first and peds and general surgery. All three of those specialties did a study and found that if the student, again, could clear between a 215 and a 220, depending upon that study, they were at functionally no risk of failing any of those exams. For the other specialties, it's sort of even lower. In medicine, emergency medicine, obstetrics, the cutoff was somewhere around a 200 or a 205. So we know that if a person, again, passes STEP, they're probably at a minimum level of competence. So again, it's excellent at telling us who's at risk. It's not so excellent at telling us what the ceiling is. Okay, so this is all to say that Step 1 does have some very reasonable uses. Of course, my interest in is what it doesn't tell us too, because I think this is the other sort of half of the story. I'll also say that in that general surgery study, it couldn't even really predict who dropped out. People with lower scores, some of them hung on. Some people with higher scores actually left. So Step 1, the short answer is that it doesn't tell us behavior. Right? It's a standardized test. It doesn't tell me what else the learner is going to do. So just like my ability to drive a car predicts my ability to drive a truck, My ability to drive a car doesn't tell you how I'll paint one day. Okay, and that's sort of the step one relationship. So I'm not going to go through every study, but I'll go through some of my favorites. Several small-scale studies basically tell us that when you compare people's step one scores to what their preceptors said about them, there was basically no relationship. It just didn't matter that much. My personal favorite study is the one of the surgery residents. So there was a surgery program that basically came up with a performance score for their first-year residents. And that took into consideration academic performance, what patients said about you, what your preceptors said about you. And again, no functional relationship with step one. In that general surgery study, we didn't tell us who would leave the program. There's a great study of neurosurgeons, often thought to be some of the highest, competition type of people. Step one made no difference in any of the things that a lot of them cared about. So academic rank, their H-index score for publications, how many are the dollar value of their NIH grants, and even their certification status. And there were some low scorers, because the question is always, but aren't all neurosurgeons excellent scorers? Not everybody in the sample was. It didn't predict future disciplinary action, so it doesn't tell us much about the person's ethics. And then my other favorite study in this crew is they took a bunch of residents in internal medicine, emergency medicine, and some fellows, I believe, in nephrology, and they basically gave them all these skill tests. And again, shouldn't really surprise anybody, but your step one score didn't tell us how good you were at thoracentesis. Yeah, I know. People are shocked. I could see the looks on the faces. Okay. And people are always asking, well, why? And there might be a couple reasons for this. And the first one is that for all of these things, step 2 CK was a better predictor. Possibly because it's more clinically oriented. Possibly because step 1 information is poorly retained even a year later. So there's a fabulous thing the NBME did, where if anybody's taken the shelf exam or the step 1 or step 2, you know that some of those questions aren't graded, right? They're experimental. So some of those experimental questions on step 2 CK were actually step 1 questions, because they wanted to see how a step 2 taker did. And they performed worse than first-time step takers. So a lot of that step 1 knowledge just kind of falls out your ear in clinical life. And so what we have here is kind of an inherent mismatch, actually, between what the exam actually tells us and maybe what we're asking it to tell us. But yet, when you survey residency program directors, they're very honest about what they want. This is, according to last year's program director survey, in ranked order, what a program director wanted from their candidate. And so 8 out of the 11, which I helpfully color-coded in hot pink, are not really measured by a step 1 exam. The top 5, in fact, were not really measured by a step 1 exam. It doesn't tell us how professional or competent you are clinically, what your patients think about you or your outcomes with those patients, your ethics, or how well you speak to others. So essentially, you have program directors who want this set of qualities, but we have a test that doesn't tell us about those qualities. And so this is not to blame anybody, because I think this quote from Dave Johnson from the Federation of State Medical Boards says it really well. It serves first a licensing purpose. That's what it's good at. But we accept that there's this broader context of stakeholders from both students, undergrad med ed, and grad med ed. And I always compare it to the classic, everybody blindfolded touching the elephant. Nobody here is doing wrong. It's that we're all touching a different part of the elephant, trying to optimize our part of the elephant. And as a result, you don't really get the prettiest elephant. We should all just work together on the beauty of our pachyderms. Okay? Word of the day calendar. No, okay. So if we're looking at the challenges for GME, why would you use step 1 then if it doesn't tell you what you want to know? Well, there's some really good reasons you might do that. There's an increasing number of applications. If anybody in here is on the residency side, you're probably totally overwhelmed with this. By some estimates in the last 10 to 12 years, first year enrollment at allopathic medical schools is up 30%. By some estimates, osteopathic first year enrollment is over 150% up. Residency training positions are basically stuck at between 1% and 2% per year growth, and that's largely because we haven't put meaningful federal funding increases into this since the late 90s. It's nobody's fault in the room, but this is where we're sitting. In the room. And so students now are compounding this by submitting more and more applications. To our best guess, most students submit about 40 residency applications. which if we unpack, though, the specialties, this is where it gets fun. Back in 2014, the average ortho applicant submitted 67. 5 years later, they're at 80 per person. Now, lest you think this is only a thing in the really competitive, ultra-competitive specialties, neuro went from about 19 to about 25 or 26. So this is consistent across specialties, and what program directors are telling us is that they have an average of 7 spots for which they get over 900 applications. I don't know about you, but 10 minutes per application, I wouldn't have time in my day to do this. And so what do you go toward? An easier objective metric. This is compounded by the fact that the feedback that sometimes we get from grad med ed is that there's no objective way. So to create equity and access and a lot of other good things around wellness, most med schools are pass-fail. Many have eliminated AOA. Some have eliminated ranking and clerkship grades. And in a recent survey of letters of recommendation, somehow, and get ready for this math, 75% of the students were above average. Again, philosophy major, but that math doesn't work out. So the message we're getting is that there's no objective way to assess a candidate and there's no time to do it in. So what do? They optimize their part of the elephant. And so if you're looking at the people that are using step 1 to decide whether to grant you an interview, it is most programs, okay? Every specialty but neurology, family medicine, and plastics, over 90% of responding program directors said, yes, we absolutely use step 1 to decide whether you are interviewed. And you'll notice that there's 7 or 8 specialties at the top where it is 100%. Okay, so if you're a student and you see this data, imagine how that makes you feel. Especially when many programs admit to using target scores. Now, our students don't call these target scores. They're called cutoff scores, okay, because they know that under a certain score, you might be cut out, okay? In orthopedics, 98% of programs admit to having one of these. Even in psychiatry, more than a third are saying, yeah, we do have a bottom score where, we just have to take you out of the filter. And so as a result, it's not surprising what happens, right? So the students are over on their part of the elephant, and they're thinking, well, I see this data, I know what's happening, and so my job is to maximize my step 1 score. So what does that mean? It means that in the last 20 years, the average national step 1 score has gone up 15 points. The average step 1 score in 1999 and 2000 and 2001 was a 215. Today, that is the 22nd percentile. Okay, so even a physician who graduated not that long ago is starting to look real average. And that's challenging for people, okay? It's gone up fairly consistently. Now, on a short enough timeline, it's kind of insidious, right? You're thinking this doesn't really matter. What's 1 point? Well, what if you got your PhD while you were in med school? 7 years, that average did meaningfully change. There are people in my field who talk about whether there's a ceiling on this, and the reality is I honestly don't know. I don't know what the ceiling is. And so if you're a student, this is the data you would see. These are the average step scores of matched U.S. allopathic seniors by specialty, and that nice pink line is where the national average score is. So if you're a student, you see that even getting the national average doesn't look that good to you. Because family medicine, PM&R, psych, and peds, their average match score is below the national average, but every other specialty's match average is above that. And so I talk about this as like plane crash logic. How many people like to fly in the room? I love to fly. Some people hate it. They're like, okay, my mother like won't get on a plane unless you're like dragging her. And it's plane crash logic. We know that planes are the safest form of transit, right? But when a plane crashes, that's all somebody who's afraid of flying can think of. So even if you tell a student, national match rate's 94%, the vast majority of Sinai students match in their top 2 or 3 match choices, they're thinking, I know somebody who didn't, or I read on the internet someone who didn't, and that's the plane crashing. So I'm going to do everything I can to avert that disaster, okay? And so what do? The polite term for this thing is called the parallel curriculum. And really what it comes from is students perceiving that the home curriculum isn't going to gear them to STEP. And faculty are always like, but I'm teaching all of that. And it's like, well, yes, of course you are. But are you teaching it in a way that gets a superior score? Because that's what people want. You're certainly teaching it in a way and enough to pass, but that's not the student view on this. And it's interesting. So I'm not telling tales out of school because the folks from Stanford have put this in perspective pieces, but they were doing an internal site survey for their LCME visit back in 2012. And it came up over and over again, even at Stanford, that students thought they were not being prepared. And in fact, 70% of them said they had anxiety about this at Stanford. So there is a parallel curriculum to prepare for step one. It's transmitted on the internet. You know, it's like the underground. It's not that underground, to be honest. If any of you go to Reddit or Student Doctor Network, you can see what's going on. I hang out there. I won't dox myself to the room, but I'm there. And if you want some advice from Reddit, this was all taken from one thread. And the precipitating question was that a student said, I love class. I want to keep going to class. How can I get a good step score? And these were the responses in order. I did not really curate these. Only did board studying with some cramming for school 2 to 3 days before the exams. Didn't take notes like I usually did. You just need to be okay with letting your grades dip a bit during this time and focus on boards. If your class grades are doing well, then yes, you could spend more time on boards. Avoid as much class time as you can. Double speed the class videos the night before. Mirror your course material. Study boards until a couple of days before the exam, and then just 2 times the lectures. That's 2 times speed for all of you watching at home. I don't know what you're capable of doing at 2 times speed. I'm not capable of doing much at all at 2 times speed. Running, walking, thinking. And then use board materials as pre-work for lecture, and then watch lecture on 2.5. If you ever wanted to know, if you're faculty in the room and you ever wanted to know what you sounded like as Mickey Mouse, highly recommended stuff, okay? Now, the crazy thing is that this works. So I'd be lying to you if I told you this was ineffective. And in fact, one school did a study where the earlier students started using these board resources, the better they did do. So the students aren't wrong. It just makes us uncomfortable. This, in fact, was taken from this year's third-year class who just took STEP. There were 78 of them responding, and they were asked, preparing for classes, prepared me for STEP. So just like the students at Stanford, there's this perception that it is not happening. So what is this parallel curriculum? Reddit calls this UFAPs, UWorld, First Aid, Pathoma, and Sketchy. Okay, so I'll go through what those are very briefly for those in the room who may not know. UWorld is the gold standard question bank. And I'm going to go through prices and times if everybody doesn't mind, so we can get like the scope of this thing. UWorld has 2,818 questions as of this morning, and I say as of this morning because they add more all the time. And it'll run you almost $500 for 6 months. First Aid is 700 pages. I've never known a student able to read more than 10 pages in an hour, and I'm including myself. I've tried. That thing's $54, delivering on December 12th, should you want the 2020 edition. Pathoma costs about $130 for a year. It's 34 and a half hours of video. Sketchy Micro and Sketchy Farm are several $100s for the year. They each have 100 videos. So really, if you add up all the hours this would take you, you're looking at 10 hours a week over 10 months. It is a second job. It is a research commitment. That's not even the whole story, though, because Anki. Anybody here use Anki ever? I've used it for foreign language stuff. I know. Okay. The current popular Step 1 deck is called the King overhaul of the Blue Galaxy's version of Zonky. Ooh. Don't worry, I hate myself sometimes too. Okay. And so right now, what that has in it is it's a spaced repetition flashcard app that basically has all the facts from those top 4 resources in it. And today it is hovering at almost 30,000 cards. If you did it over an 18-month period, you'd see 80 new cards a day, but they will repeat on you because for memory, they spaced repeat. If you were aiming to finish this, and many of my students do, you're looking at a 4-hour-a-day commitment, starting very early in the microbio class. Some students on top of that want to do a review series like Boards and Beyond. That's $200 for a year, over 200 hours of video. So all this is to say, but are our students doing that? Yes, they are. Okay. And so in last year's survey, Most students were studying an average of like 2.5 hours a day in December, and that went up to almost 7 hours a day during the renal class. There were students studying over 10 hours per day, not many, but they were there as early as December. So our students used all those core resources, and the reason I give that second bullet is I just want to give the scope of how much else there is to buy. There's 3 or 4 Q banks, Amboss, RX, Kaplan. There are other visual mnemonic devices, Pixar-Eyes, Sketchy Path, Osmosis. There's Golgin's Pathology for those of you who may have used that, okay? The opportunities to hoard stuff are endless. And more than half of those 78 students used what I call a comprehensive Anki deck. So that's like a Zonki. You're looking at 20 to 30,000 cards. Okay, so what are the effects of this climate? I think I've sold you on the fact that this is basically a second job for a lot of our second years and increasingly some of our first years. So 3 big buckets of sort of outcomes. Number one, I'm not saying this because I love to talk about anxiety, but I love to talk about anxiety. There is high anxiety around step 1. Now, some of that's basic test anxiety. You have to sit in a room for 8 hours and show what you know. That's inherently stressful. But there's also anxiety around one's professional future. If you've made it to medical school and you want to be a doctor, you have worked very, very, very hard. And you trust that if you work hard enough, you'll get a reasonable outcome. For a lot of our students, this is the first time that that is in question. Even if I do everything I have to do, will it work out? And I think the answer is, I don't know. And then there's even anxiety about what do I pick and how do I pay for it. I'll talk later about how our institution has done a good job about buying a lot of these resources, but not every institution is there. So you could spend a lot of time and anxiety picking your resources and then about $1,000 at least buying them. If you're already worried about debt, and we have a lot of data suggesting that debt is an anxiety driver in medical students, this is really just putting more on it. Where I really get interested in this, and I won't ask the students in the room to comment, but step 1 absolutely causes distress socially. Some of this is the comparison of self to others. I had a student last year who I totally love, and she was in my office very upset, and she said, I know, my mother always says comparison is the thief of joy. I was like, yes, it is. And I've said that to other students since, but it's hard not to. If all your roommates are doing this and you choose something different, aren't you worrying maybe they know something I don't? Maybe that guy on Reddit knows something I don't. Maybe my, roommate's girlfriend knows something I don't. That's anxiety producing. I think what's even more sort of grim is the disagreement about what's appropriate behavior. Step 1 challenges social norms. When all of our students came to med school, we selected them for being high empathy, high ethics people, and I believe they are. But I think that ethical rigidity is a luxury of those with a lot of time and a lot of decisions. So if you know you have to get through 4 hours of cards today, and you have a mandatory patient presentation and no one is looking at you, will you open your cards? We all want to say no, right? I don't know that we can all credibly say no. And then what you have is saying, well, she's doing it. Is she saying that my time's not valuable? Or I don't think that's right. And so you tear sort of at the fabric of your class culture. Studying for STEP can also contribute to burnout. If you've studied for step 1, you're probably like, please don't talk about it, I remember. Okay. But really, if you're spending at least 10 hours a week doing this, think about an activity that you currently do for 10 hours a week. Now imagine it goes poof and it's gone. Okay, that could be research, that could be volunteering, that could be time with loved ones, that could be playing the cello. Up to you. But that's gone. A lot of these resources you have to consume alone. I tell students I would watch Pathoma with my friends. Like, there's no reason we can't open some nachos and all watch Pathoma together. But certain things like Anki and question banks, you kind of just have to do for yourself. So all those hours you're now alone. We know burnout comes from lack of connection. That's sort of the definition. And then if you're not comfortable with your own decision and you're always in a state of anxiety, it's exhausting because it's not enough to just do the task. You're thinking, well, what about this other thing? And so a guy named Stuart Slavin at St. Louis actually wrote a paper. He does my job over there, and he wrote sort of the buckets of destructive mindsets of medical students. And he didn't write the paper about step 1, but all this stuff is basically the step 1 anti-wellness kind of issue. Viewing performance as identity. I had a student who was meeting with me about step 2. And I said, okay, what are your score goals? And they're like, well, I'm a 230, so I need X. And I'm like, no. No one is a 230. Like, you took a test and got a 230. Overuse of comparison, as I just said. What I like to call maladaptive perfectionism. That there is no ceiling on achievement. Step 1's kind of like water. You're always thinking, could I do more? Imposter syndrome or phenomenon. You're looking around and thinking, well, the average is so high. Surely I won't be average. All those people had more money. They went to Ivy League schools and I didn't. Whatever your thing is, this is when it comes out. Cognitive distortions. We all know these. Catastrophization is a huge one during step 1. My favorite is I didn't do my questions yesterday and thus I will fail. And I'm like, look, I'm not chubby because I ate a cupcake one time. Okay, I've eaten a lot of cupcakes. Okay? Nobody fails step 1 because they didn't do questions on one day. But this is the thinking. I'm behind. I am perpetually behind. Feelings of shame, embarrassment, what they call the Stanford duck. You know, everything's fine, but the legs are paddling under the water. These are the people that are like, everything's great. You don't have to say everything's great if it's not great, but I think there is the culture that says you do. And then chasing success at the expense of something else you might find more meaningful. And then, of course, professional derailment. This is a real Reddit post from last month. I saw it, and I saved it for this talk. This is sad to me. I just found out I did really poorly on STEP, devastated, barely passing score below 200. I want to do psychiatry. There is no other field I want to do. I knew early on I wanted to do it. But the field is getting more competitive and it's pointless to apply. I'd be miserable doing family medicine. I'd have no motivation unless it's psychiatry. I'd rather quit med school. Should I just quit? And this person has come to the internet with this question, which for them is legitimate. Are we really ready to lose a psychiatrist this way? I'm not convinced. And in fact, last year, 28% of our respondents sought out mental health care. I don't think that's a bad thing. I think that's a great thing. And 95% found it helpful. It's just to let you know that. And the question was phrased like 4-step, okay? And they found it helpful, okay? Now, I'm not done, though, because we have the erosion of wellness, we have all this stuff, but I want to talk about how step 1 might be informing bias in the physician workforce. It's not a pretty picture. We have a lot of studies as recent as 2019 suggesting that test scores may be correlated with things that have nothing to do with your own effort or intelligence, namely how much money your parents have, what race you are, what your gender is, and if you're a nice traditional age for med school. Some of the specialties with the highest mean STEP scores are also disproportionately white and male, okay? I think, out of the top specialties that women residents went into, top 10, only derm was also a top 10 paying specialty. Some of the least diverse specialties, like plastics, like ortho, are also the most competitive in STEP. So we have to worry what we're doing with this exam. There was a very interesting study of internal medicine where they retroactively went into the residents and they imposed sort of fake threshold scores to see if we had this threshold score, who would we have interviewed? And they would have interviewed fewer African-American candidates. So this is actually somewhat dangerous. Specifically also because, as I said, these things are expensive, not everybody can afford them. Are we enforcing privilege with this test? To say nothing of the test prep materials themselves. Now, I want to be clear with everybody in the room, I am not a physician, I did not major in any science. But when I got this job, I did UWorld, because I wanted to know what the kids were doing. And what I found out, okay, is that African-American people have sarcoidosis and sickle cell. I found out that if you're a Korean man with stomach pain, it's definitely H. pylori. And I found out if you're overweight and female, you probably have PCOS or maybe lupus on a bad day, okay? And all this can be gleaned by doing UWorld. And it's not the way we would want our students to engage in clinical practice. So there was a great study in 2017 where they went through UWorld and they actually tried to quantify this sort of feeling that a lot of people had using the bank. And so 20% of those 2,800 questions had racial or ethnic information in it. That information was also out of proportion to the American population. There weren't even any questions about Native Hawaiian or Pacific Islanders. It was disproportionately white. And they found that it was, quote, used as a proxy for genetics, social class, culture, or behavior. Now, all of our students know that UWorld is just for a test, and I'm not saying that they're not agents of their own thinking, but I also think that if the fish is in the water enough, it takes a drink. Okay, so we have to be careful. If you're still in doubt, I'm about to show you a picture from Sketchy Micro, which is a visual mnemonic device that works perfectly well to memorize the characteristics of microbes. And so what I'm about to show you is the sketch for cholera. Okay? Yes, this is the sketch for cholera. Yeah, that's the reaction a lot of people have to it. It is called, the title of the sketch is Captain Cholera's Base Camp. It takes place, as the speaker will tell you, in a South Asian country. Okay, now, will it help you remember the characteristics of cholera? Absolutely. Is it racially comfortable? It is not. Okay, and so that's where we're at with this. And so people are smart. People have noticed sort of students are doing one thing, undergrad med ed's trying to do one thing, grad med ed's trying to do another, and nobody's that happy. So this is where we get into the, like, what is going on to address this kind of part of the talk. I'm winding down, I promise. Okay? And so there's been a lot of discussion at the national level on pass-fail scoring. Because usually when I get to this part in the information, everybody's like, pass-fail. But I think it's important to trouble those waters. So reasons for pass-fail scoring are numerous. It puts the USMLE Step 1 back as a licensure exam, which we know is what it's good at. It would increase the work-life balance of medical students. However, I will say that the president of the NBME said that if this happened, students would use that balance to, quote, watch Netflix. He then apologized to students over Twitter. It would allow for more curricular innovation, and it would reduce sort of the impact on self-concept. So I know everybody's ready to go pass-fail, except when we look at the problem. It would reduce the competitiveness of certain students, not just IMGs, but people from lower ranked or tiered med schools, right? If you got into maybe not your first choice med school, part of you is thinking, I'm going to crush Step 1, and then everybody will know. Not if it went pass-fail. It possibly pressures UME to revert to grading or ranking. Now, whether that's something we want to be involved in is a whole other discussion. But it puts pressure to do something that we already decided wasn't good for our students. It would remove an objective criteria for, as we said, already overwhelmed program directors. And the other argument is that, the exam's psychometrically valid. It's studied in tens of thousands of sample sizes every year. So some of the things that have come up, should we keep it the same? Should it go pass-fail? Should we go with categorical scoring, your quartile 1, 2, and 3? That one I always laugh at because then I'd have students being like, Lauren, I need to be quartile 3. It would just change the conversation's language, not its character. The more interesting ones are scoring Step 2 CS numerically and aggregating it with 1 and 2 CK. Optional numeric scoring, I got a really good score, I'm going to give it to you. Inclusion of other data into the USMLE, so, sort of weighing it out with certain social factors, or even just changing timing and recipients of the score release. You don't get it till after an interview offer, let's say. So they had a conference, because that's what we love to do as educators and medical people. We have a conference. And so they invited some stakeholders down to Philly to talk about it back in March. It was co-sponsored by basically the 5 organizations that it really matters to. And then they opened it up for 6 weeks of open commentary. There were tens of thousands of responses. And what came out was that everybody really cares about this issue, but no one agrees. So only 2% on whether it should go pass-fail were neutral, which I think is kind of entertaining. 35% wanted it to go pass-fail, 62% did not. Opinions trended unsurprisingly by where you were sitting in the medical system. So folks like clerkship and course directors really liked pass-fail scoring. Advisors liked pass-fail scoring. Program directors really didn't. Students were a 50-50 split. And that's the part that I think is most interesting. Because I think even when you try to revert to pleasing students, it may not be possible in this framework. And so where does that leave us? They issued 4 recommendations. Okay. So they would like to reduce the adverse impact of overemphasis. They would like to accelerate research on the issue. They would like to minimize racial and demographic differences. and they want to convene a cross-organizational panel to create solutions for the UME-GME transition. And what that means is that where they've left it, because I just went with a session with them last week, or earlier this week, time is slipping away from me, they're now putting it on the Coalition for Physician Accountability to do a comprehensive and timely review of the undergrad med ed to grad med ed transition. So what I will say is that we might be waiting for quite a while to hear whether this is going to be pass-fail, to stay the same, or something else. So that leaves us with like stuff to do, right? So I'm going to try to be, this is when I switch in the talk, when I'm winding down, I'm going to be an optimist now, okay? Cue optimism, okay? So what can organizations do? So organizations can absolutely engage in national advocacy, not just for increased residency positions, but for anything that they think would improve the med ed climate. They can also accelerate research on the value of step one to patient outcomes. Because if you do this, you give program directors a tool. If program directors know that, say, under a 220, your learner is at risk, but over a 220, they're all great, easy. Now I have a cut score. And it's a fair one, not a 250 just because everyone else got one. Or you find out that, step one doesn't matter as much as, say, first-year grades in a correlation with professionalism flags, for instance. But we've not done enough exploration on what actually predicts the type of resident and physician we want. Undergrad med ed can frankly provide targeted career advisement. We actually just got a senior director of career advisement, Dr. Monica Dweck, who's going to be amazing. I think every school should do this. The AAMC just released a pretty interesting data set about, in each specialty, at what step score, how many applications is diminishing returns. So for example, if I got a 230 and I want to go into internal medicine, at 30 applications, do I hit diminishing returns? At 40? And it'll tell you. And the nice thing about that is it'll help us guide our students to not take part in that application frenzy we were talking about earlier. Provide low or no cost step one resources and wellness resources. So here our students are very fortunate. They get 6 months of UWorld, they get a year of Pathoma. Okay, they get NBME customized assessments along the way to give them exposure to board style questions. We have student training mental health. They can come see me. And last year, just so you know, I saw 137 out of 140, so like they are using the resources. Yeah, it was fun. We can adapt curricula for step one success, and that doesn't mean changing necessarily what you're teaching. We had a course director last year who literally just made the edit of telling students, oh, this is here in first aid. That's it. And students have come to me this year and say, that was great, now I felt better, And then early, honest, data-driven support of student plans. So I think students often complain, not just here, but sort of nationally, that my mentor, my advisor, my professor, my learning specialist told me, don't worry about STEP, it's going to be fine. And I think what the data shows us that without early targeted effort, it may actually not be fine. And so I think we need to start telling people, well, in this specialty, this is what you're going for, this is how you would get it. It's not on the slide, but I think the other thing that undergrad med ed could do is come up with ways to explain their students to programs in an objective, standardized way. I know, emergency medicine has asked for the standard letter, and they've been very happy with that, according to one of the studies of that. Grad med ed can develop early assurance residency programs. There's several here now, which I think is great. And just develop processes and thresholds for better residency screening. For instance, if you study your residents and you find out the problematic ones actually, had a first-time failure of Step 2 CS, then maybe that's what you're screening for. Or that your really rock star residents had more than 10 publications. Maybe that's what you go for instead. And then distribute resources to allow for more holistic review, and that's really, really hard. But I think without more resources to do the job would be very hard to do. We don't want to let students off the hook. I think students, it's on them to sort of be strategic in their goals. I met with somebody today, in fact, 20 minutes before walking over here, who is a first year and wants to start studying for STEP. And I said, okay, well, if you're starting now, I'm going to take it to mean you have a very ambitious score goal. Is that true? And the student said, no, I really want to be a pathologist. And I said, okay, so. And the student said, but I need to know I did my best. And so I think it's on the student, but also on us to help them really ask what the best means for you. Students should actually proactively seek advice. April is not the time to be worrying about this. And then I would say maintain open dialogue and empathy with other stakeholders, including each other. It's hard enough without turning on each other, so we have to maintain the open dialogue, telling people how it is. And so that sort of wraps up what I have to say. Anybody in here can call me, email me, but I'll also just take questions.